in our series of healthy aging. We welcome you to rainy Ann Arbor this morning. My name is Julie Brown. I'm the Assistant Director of the OLLI programs, and I have the pleasure of moderating today's lecture. I'd like to thank the following planning committee and the programs that helped to make this series possible: the U of M Geriatrics Department, Turner Senior Wellness Program, OLLI, Silver Club Memory Programs, TASC, the Turner African American Services Council, and IHPI, Institute of Healthcare Policy and Innovation, and of course, the National Poll on Aging. Our topic today is Healthy Aging, Sleeping Well with Dr. Greta Ragland, and the role of exercise in brain health with Dr. Jacob House. I'll introduce our two speakers in just a moment. First, we have a few housekeeping details. I'm sure most of us are familiar with Zoom at this point, but in case you're still new or have some questions, I have a few tips on navigating Zoom. This is our presentation software platform that you're on. And when you're navigating the Zoom webinar platform, the main thing to know is the Q&A icon. To submit a question for either of our presenters, simply click the Q&A icon, which is at the center bottom of your viewing window. You'll type and submit your question, and it will go to me, the moderator. And after the presentations at around 11 o'clock, I will give your questions to our speakers to answer. If you have a question for one of the specific speakers, please make that clear in your Q&A so I can give it to the right person. There's also a chat icon. Please don't use the chat icon for questions for our speakers. We kind of want to keep that separate and use the chat icon for technical questions. If you have, a Zoom issue, and we will try to help you out there. Please note that we now have a closed caption option for you to use if you wish. On your Zoom computer screen, you should see an icon labeled CC in the meeting controls. Click on that for closed captions, basically a live transcript of the presentation. Finally, if you are having any technical issues, such as your screen freezing up, the best way to solve those issues is to actually leave the webinar and to come back in. Just like the old saying, you turn it off and turn it back on again, and hopefully it works better. But if your technical difficulties do persist, please call the Turner office at 734-998-9353. I'd like to call your attention to the next lecture in our series next Friday, April 22nd at 10 a.m. Our lecture will be Caring for a Loved One with Dementia. So make sure to mark that down on your calendars. Now on to today's lecture. As always, we must give our legal disclaimer. The views expressed during the lecture and the Q&A do not necessarily reflect those of the University of Michigan. We will have about a 1-hour presentation followed by a 30-minute Q&A, and you can type your questions into the Q&A at any time. So you don't have to wait until 11 o'clock. But we will be answering the questions around 11 o'clock. They'll just stay there in the Q&A. So if you think about it during one of the presentations, you have a question come up, please feel free to type that in and we will get to it during that Q&A period. It is now my pleasure to introduce our speakers for today. Dr. Greta Ragland is a clinical psychologist and is certified in behavioral sleep medicine. She's a clinical assistant professor at the University of Michigan Department of Psychiatry, where she sees patients in the behavioral sleep medicine and women and infants mental health clinics and participates in research in the Sleep and Circadian Research Laboratory. Dr. Jacob House is an associate professor of movement science and director of the Human Bioenergetics Laboratory, HBL, at the University of Michigan School of Kinesiology. Before his time at U of M, Dr. House taught and researched in the Department of Kinesiology and Nutrition at the University of Illinois at Chicago. He completed his postdoctoral training at the Cleveland Clinic and his PhD in Human Bioenergetics at Ball State University. Dr. House and his lab research exercise physiology and metabolism as it pertains to obesity, insulin resistance, diabetes, and how exercise and diet can reverse or prevent these conditions. A current focus of Dr. House and his laboratory has been trying to understand how exercise is important for the treatment of complications associated with diabetes, including diabetes-related cognitive decline, peripheral neuropathy, and healing of diabetic foot ulcers. And now it's my pleasure to introduce to you our speakers. We're going to begin with Dr. Greta Ragland this morning. Dr. Ragland, the floor is yours.
Thank you so much, Julie, and thank you everyone for being here. I'm just going to pull up some slides and share my screen with all of you so that you can see my visual aids here. Give me one moment to get that up. All right, I appreciate you all being here and giving me the opportunity to talk with you today about sleep and healthy aging. So the focus of my talk is going to be on kind of wellness over the lifespan with regard to sleep. So first, I just would like to say I have no conflicts of interest to disclose as I'm going through the presentation. And when we're thinking about sleep, I just want to keep in mind that it is something that we do every single day. And so it does have a great deal of importance in terms of our overall wellness. The goals for today are to talk about how sleep changes as we age, which particular sleep disorders become more common as we grow older, and then some general tips for what we can do to ensure that we have a good night of sleep. So the first area that we're going to talk about is kind of how sleep changes overall as we age. And this is speaking in generalizations because everybody has a different relationship with sleep, but we're going to talk about just sort of some, on average, how things differ as we grow older. And so just a couple of questions. So the first sort of idea that some people have about sleep is that during sleep, your brain rests. So this is actually false. In fact, sleep is a very active and complex biological process. So no organ or system within your body actually shuts down during sleep. Rather, there's just sort of some transitions in terms of what actions or systems are more active or more sedate during sleep. And many parts of the brain are actually as active, if not more active, than they are during sleep than they are when we're awake. So your brain is actually doing a whole lot while you're sleeping. Another idea that people have is that when they're falling asleep in front of the TV, it's because they're watching something really boring or because the content is actually not engaging. What we know is that that's false. In fact, environmental factors can help to unmask sleepiness or make sleepiness more apparent, but they don't actually cause you to be sleepy. So a well-rested individual, somebody who's getting good quality sleep, won't fall asleep even during the most boring television show. So if you're finding yourself falling asleep, in the evening or even during the day, it could be because you're getting insufficient sleep or that your sleep quality is not as high as we would like. Another common thought is that snoring is not as harmful or is not harmful as long as it doesn't disturb others or wake you up. It's just sort of a fact of life. In fact, this can be false. So snoring can be a sign of sleep apnea, a sleep disorder characterized by stopping breathing or the reduction of airflow at night during sleep. And this can lead to strained heart and cardiovascular systems, as well as a host of other health complications. And so snoring is actually something that we want to make sure that we're paying attention to. So this is just to make the point that sometimes we have some misperceptions about sleep that can contribute to having poor quality sleep or overall health problems. And so we're going to talk a little bit today about some of the health problems that can come up from poor sleep, as well as some of the sleep disorders that can occur as we age. The first thing, though, that I want to talk to you about is kind of what sleep should look like or looks like in general as we age. So there are two kind of broad stages of sleep. There's non-REM sleep, which is about 3/4 of the night of our sleep. And it's characterized by an inactive brain in a movable body. And as I said earlier, our brain isn't ever fully inactive, but it is a more restful state for our brain, and our body is still able to move. REM sleep makes up about 1/4 of the night, and it is characterized by a highly activated brain in a paralyzed body. So this is the sleep that's often associated with dreams. And during that phase of sleep, we're unable to actually move our body, assuming that all of our programming is working correctly. So if we break down non-REM sleep, there are actually 4 sort of sub-stages of non-REM sleep. So stage 1 here is kind of the transition between wakefulness and sleep. It's called light sleep, and during that phase, we're easily awoken. We experience some body, eye, and muscle movement, and it lasts about 5 minutes during the transition into stage 2 sleep, which is also a light sleep. This is where we spend most of our time throughout the night, and it involves the cessation of eye movement, and your heart rate begins to slow down. Brain wave and activity levels become slow, and again, this stage lasts about 10 to 20 minutes as we transition into our deep sleep stage of stage 3. Once we're into stage 3 sleep, it's difficult to be awoken, and you'd likely feel cranky or disoriented if you were woken up in this stage. There are slow brain waves that appear during this period as we transition into stage 4 sleep, which is sort of the most intense level of deep sleep. And it is an essential stage for proper sleep and for full restedness. Then the last stage, like I mentioned earlier, is this REM or rapid eye movement dream sleep. There's a lot of eye movement, but the rest of the body is still. The brain activity increases, and there's also an increase in heart rate and blood pressure during the REM stage of sleep. So in a young adult, this is kind of what our sleep architecture looks like. And you can see it sort of looks like the cityscape of a big city with skyscrapers. What happens is we sort of descend in a stepwise fashion into this non-REM deep sleep, and then in a stepwise fashion back up to our REM sleep. And you can see that over the course of the night, we spend time kind of dipping in and out of the stages of non-REM sleep and then back up into REM. Over the course of the night, REM sleep becomes kind of more frequent, and our deep sleep really tends to happen at the beginning of the night, whereas we're in the lighter stages of sleep in the morning. Now, as we age, our sleep architecture changes. So this is, again, that graphic that we saw on the previous slide with the young adults up at the top. Whereas for older individuals, there tends to be less of the deep sleep, sometimes not even any of the stage 4 sleep. And REM activity tends to be broken up more during the night, and we tend to spend more time in the lighter stages of sleep. There are also more periods of wakefulness, which are these little peaks along the way, than there are as for younger adults. Along those lines, not only does our sleep architecture change, but often our need for sleep changes. So you can see that as we age, we tend to need less sleep than, for instance, a baby. And when we get into older age, we tend to need a little bit less sleep, although on average, it's similar to younger adults in that 7 to 8 range. But there are more individuals who are doing well with 5 to 6 hours of sleep, and the kind of higher need for sleep group tends to diminish a little bit. So in general, we need just a little bit less sleep as we age, though not often a huge amount less. And as I mentioned earlier, when we were looking at the sleep architecture slide, you tend to spend more time awake overnight, and you tend to spend less time in your REM stage of sleep. So you tend to have less of that dream sleep, and it is broken up a little bit more over the course of the night. This slide indicates that sleep becomes more efficient or less efficient with age. And what I mean by efficiency is that it means we actually spend less of our time in bed actually sleeping. This is demonstrated by the fact that there are more of these moments of wakefulness over the course of the night. And so your sleep may feel a little bit more broken as you age. And even in good sleepers, there's an increase in terms of nighttime awakenings. So there is a high degree of variability in terms of the number of awakenings per night based on age and gender, even in this single data set. But the bottom line is that although there is variability, people tend to have periods of wakefulness over the course of the night, and that those periods of wakefulness increase pretty gradually after about the age of 30. So for younger adults, as many as 4 awakenings per night is not uncommon. And for older individuals, it can be as high as 11 during kind of the 8th decade of life. And so sometimes this is reassuring to folks in the sense that they may feel like their nighttime wakefulness is bad for their sleep or means that they're getting poor quality sleep, but it doesn't necessarily indicate that. It could just be that there's changing sleep architecture and that this is just part of your healthy sleep. So as we age, there are things in our sleep that become kind of more frequent and less frequent. So in general, it takes more time to fall asleep as we age. We're more likely to take daytime naps. We're more likely to have early morning awakenings, lighter sleep, and overall awakenings during the night. At the same time, our body produces less melatonin at night, so there's less sort of drive to fall asleep at nighttime. We experience less deep sleep, less REM sleep, and less overall sleep. There's also less flexibility with regard to scheduling changes as we age, and we tend to feel a little bit less rested after awakening. Part of this, and we'll talk about this a little bit more later, is that as we age, we also tend to have less exposure to bright light, which is an important cue for our sleep system. As we age, about 50% of older adults report sleep difficulties objectively or subjectively. So a question that comes up really commonly is, why are sleep disturbances more common as we age? And there are a number of factors that increase increase sleep difficulties as we age, including increase in medical conditions that can increase sleep problems like chronic pain, things like that. There's also an increase in use of medications that can affect sleep, either by making us drowsy during the day or agitated at nighttime. There are also associated life changes and stressors, such as retirement, less social interactions, and changes in living circumstances. So for instance, assisted living facilities can be associated with changes in routine. And there are also neurobiological changes that occur as we age, such as age-related changes to the circadian clock. Some of you may be familiar with the term circadian rhythm or the 24-hour biological clock. And one example of those changes is, for instance, the decreased melatonin secreted by our bodies as we age. So not only do we have kind of those physiological and psychosocial changes that can occur as we age, but there are also sleep disorders that become more common as we get older. Some examples of those that we'll go into in greater detail are sleep apnea, insomnia, and circadian rhythm sleep disorders, in particular, a phase advance of our circadian rhythm. And I'll talk more about what that means in just a moment. I'm going to start out by talking about sleep apnea and revisit that idea that maybe snoring is kind of benign or something that's not problematic or that we shouldn't really worry about. So snoring is one of the kind of hallmark symptoms of sleep apnea, and something that occurs because of an obstruction in the airway during sleep. So if you look at this image here, this is kind of an open or typical airway for an individual who's breathing without obstruction. You can see that sort of the tongue and the musculature of the neck stays open so that air can flow in and out without any problem. In an individual who has obstructive sleep apnea, the musculature has a little bit less muscle tension, and so it tends to kind of collapse into the airway. This means that as air comes in through the nose or mouth, it's unable to get down through the throat and into the lungs. What happens then is that your body becomes deprived of oxygen. And so your body will send a message to your brain, essentially, that you're choking. And this will cause you to wake up in order to resume breathing. When somebody has sleep apnea, depending on the severity of the sleep apnea, this can happen multiple times overnight without them even being aware of it. And so there can be sort of this unknown sleep fragmentation. What we see, the reason that they're snoring is because this area of the airway begins to vibrate because of the tightness of the airway as air tries to flow in. And so you get that kind of loud noise that comes out as a snore. Some people will also notice that they're kind of waking up snorting or gasping or choking for breath. And that can be attributed to all sorts of factors, but often it is because of a difficulty with breath over the course of the night. As I mentioned, sleep apnea is more prevalent as we age, and anywhere from 1/3 to 2/3 of adults over the age of 64 experience sleep apnea to some degree. There are a number of risk factors that can be associated with the risk of developing sleep apnea, including age and obesity. But the consequences are that there's kind of this excessive daytime sleepiness, which can lead to increased functional impairment and difficulty sort of doing the things that you would like to do during the day because of that sleepiness, as well as a tendency to doze off, for instance, while watching a boring television show. But it's also associated with numerous medical conditions and can worsen cardiovascular disease as well as cognitive impairment, especially as we age. Symptoms to look out for sleep apnea are, like I mentioned, loud snoring, waking up, gasping or choking for air or for breath. Bed partners might report snoring or the gasping and choking, and they might also say that they saw you stop breathing. Another kind of hallmark symptom of sleep apnea is unrefreshing sleep. That would mean that you'd sleep for, say, a full night, but then wake up still feeling groggy or drowsy. And this is often associated with those overnight wakenings, because even though you are in bed seeming to be asleep, you're not actually getting through your full cycle of sleep because you're periodically waking up over the course of the night. Again, it's associated with excessive daytime sleepiness, and you may notice that you're waking multiple times overnight, whether to use the restroom or just being aware of being alert over the course of the night. One of the good things about sleep apnea is that there are treatments available, and the treatments are highly effective. So the sort of go-to or gold standard treatment is positive airway pressure, or CPAP. And this involves wearing a mask or a small nose piece attached to a hose that kind of applies pressurized air to your airway in order to keep the airway from collapsing. So the air kind of pushes the airway open so that you can continue to breathe over the course of the night. Some people also use an oral appliance, kind of like a bite guard for sleep apnea in mild cases, that moves the bottom jaw forward a little bit in order to create a bit more space in the airway. The unfortunate thing about this is that it's not quite as effective as CPAP, and unfortunately we don't know whether it's going to be effective until you've paid for the oral appliance, which is why we tend to go for CPAP for most individuals. There are also some conservative options for treatment. So positional therapy, many people find that if they sleep on their side, they tend to have less apneic events, and weight loss, as well as avoidance of alcohol and smoking, can also reduce the occurrence of apneas over the course of the night. Just to show you a little bit what a PAP machine might look like, they're getting smaller and smaller and quieter, and there are all sorts of different face masks now available, not just the sort of traditional one that covers the whole face, although for many people that is the most effective. The next thing that I want to talk about a little bit is circadian rhythm disorders. So in particular, the advanced phase type symptoms. So circadian rhythm disorders involve falling asleep either much earlier or much later than you would like to, or at times that are not consistent with sort of your preferred sleep schedule. As we age, waking earlier than planned tends to be the most frequent circadian rhythm disorder that people report. So this involves kind of difficulty maintaining alertness in the evening, falling asleep much earlier than they would like to, and then waking up very early in the morning. And this involves kind of a misalignment between sort of your internal biological 24-hour clock and your desired sleep schedule. And most often in older individuals, this results in sort of frustration at having to miss things in the evening, as well as a sense that they're kind of waking up too early in the morning to be able to engage in activities that they would like to do. So this is kind of a visual representation of what these circadian rhythm disorders might look like. So in general, we're kind of sleeping on the normal body clock. If we have a phase delay, we tend to fall asleep later than we would like to, as well as waking up later than we would like to. Whereas if we have a phase advance, we're sort of falling asleep too early and waking up too early. And again, this is sort of the area that we're highlighting because it's more common as we age. The reasons for this are that we have kind of a weaker and desynchronized circadian rhythm with less amplitude. And this goes back to what we talked about with the reduction in nocturnal secretion of melatonin. So our body's just getting less signaling about when it should be awake and when it should be asleep. There are also changes in our environmental cues that are necessary for the entrainment of our circadian rhythm. And some of these cues may be weak or even missing. We have found through multiple studies that older adults tend to spend less time in bright light. And typically when we say bright light, we're talking about outdoor sunlight. This is particularly true of elderly individuals who are living in assisted living or care facilities, and generally that's because of either mobility limitations or just limitations in terms of the access to outdoor time. And so part of this is that our brain is really impacted by bright light, and that helps us to understand kind of on a cellular level when our body should be active versus inactive. So if we take away that light cueing system, it tends to make our circadian rhythm get a little bit out of whack. And again, as we age, it tends to move forward a little bit. So ways that we can address this are by introducing bright light, whether it's by getting kind of light exposure through natural light, or by using a therapy light, or simply by turning on all of the lights in your living situation. So light is really the strongest cue for circadian entrainment, and timed light exposure in the early evening can help give our body a little bit of a boost before our preferred bedtime, and help us stay up until a little bit later. Sometimes when people have that early evening light exposure, it feels almost like they've had a little bit of a cup of coffee or something like that. They tend to be a little bit more activated. But we would prefer to avoid light exposure during the desired sleep period or too early in the morning. So for instance, if you're waking up at 4 a.m., that is not the time to go outside and get a whole bunch of light exposure, because that's going to help your circadian rhythm think that that's the time it should be awake. So before your desired work time, the preference would be to maintain dim light settings and kind of stay within a dim light until your preferred wake time. This includes light emitting technology like cell phones, laptops, computer screens, and tablets. If you are using those kinds of devices during the night or the early morning, keep them at the dimmest setting so that they're not disrupting your circadian rhythm. So the other very common sleep disorder that comes up kind of at all ages, but especially in older individuals, is difficulty sleeping due to insomnia. And that can involve difficulty falling asleep, difficulty staying asleep, or waking up too early. All of these are associated with insomnia and are associated with distress or impairment in functioning during the daytime. In order to be considered insomnia, it should occur at least 3 nights per week for at least 3 months. And again, it is more common in older adults as well as in women. Now, there are a number of treatment options for insomnia, including medication treatments. Unfortunately, many of the medications or sedatives that are prescribed for people who have insomnia have risk of harm. So some of them can lead to, nighttime sleepwalking, risk of falls, and many have a long elimination time. So it can cause problems during the day, like sedation or drowsiness, again, increased risk of falls. And chronic use of these medications can be associated with cognitive impairment in the long run. It can also make you just feel a little bit more muddied and less rested during the day if you're consistently using a sedative medication at nighttime. Additionally, these medications tend not to be helpful in the long run because we often develop a tolerance for them, so that you need to take more medication in order to have the same effect. There's also something called rebound insomnia, which is when you stop taking the medication, your insomnia tends to kind of come back in full force. For those reasons, medication management is not the recommended treatment for chronic insomnia. If you have one night of bad sleep once in a while, a sleep medication can be very helpful. But if you're having chronic insomnia where it's affecting you multiple days per week for a long period of time, you can have kind of additional problems from taking medications. Instead, what we recommend is cognitive behavioral therapy for insomnia. This is a non-medication treatment that is, again, recommended as the first-line treatment for chronic insomnia by the American College of Physicians. What we find is that about 70 to 80% of patients see significant improvements in their sleep when they participate in cognitive behavioral therapy for insomnia. And the really big thing is that those improvements tend to last. The studies have shown up to 2 to 3 years after treatment. The reason for this is because it is an approach that teaches skills and coping strategies that you can continue to apply if you have further sleep disruption down the line. Along the same lines, there's another kind of therapy for insomnia called short-term behavioral therapy. And along with cognitive behavioral therapy for insomnia, they're both short-term interventions that last anywhere from 4 to 8 sessions, and they target the behaviors and thoughts that perpetuate insomnia. So some of the things that we know to perpetuate insomnia are excessive time in bed, And this can be, spending time in bed even when you're not sleeping, spending time in bed doing activities that are not related to sleep. So reading, watching TV, talking on the phone, doing work, and also going to bed early or staying in bed later than you are actually sleeping. Variable sleep schedules can also contribute to insomnia and maintaining insomnia. For instance, if you have a very different schedule on the weekends versus weekdays, or if you just don't have a particular schedule, so you're going to bed sort of all across the evening and waking up all across the morning. We know that worry about daytime deficits in sleep, so concerns about, oh my gosh, what if I don't sleep tonight? What's tomorrow going to be like? Or I haven't fallen asleep and it's been an hour. If I don't fall asleep now, I'm only going to have 5 hours to sleep. Those kinds of worries can actually lead to increased mental activation, which make it much harder to sleep. And so those are additional perpetuating factors. Daytime napping can decrease your urge to sleep at nighttime and make it more difficult for you to fall or stay asleep. Conditioned arousal in the bedroom basically means that because you've been experiencing sleep problems for a long period of time, if you have insomnia, you might actually begin to be sort of awakened just by the presence of your bed. This might look like you feel very, very sleepy when you're sitting out on the couch watching TV, you decide to go to bed, and as soon as you get into bed, you feel wide awake. And this is because your brain and your body have learned that sleep is not, or that your bed is not necessarily a place for sleep, but is rather a place for sitting there struggling to sleep and being wide awake. And so when you get into bed, your brain and body sort of automatically respond in that way. Dependence on sleep medication can be a perpetuating factor, as well as caffeine and alcohol use, which can disrupt your normal sleep architecture. So cognitive behavioral therapy for insomnia involves sort of 3 levels of treatment. There are behavioral interventions, which target excessive time in bed, irregular sleep schedules, sleep incompatible activities, such as spending too much time in bed, as well as that hyperarousal or the feelings of being too activated when you get into bed to sleep. It involves kind of 2 big behavioral strategies, which are reducing the amount of time that you spend in bed, so sleep restriction, as well as stimulus control, which is getting out of bed when you're unable to sleep, and some relaxation activities. There are also cognitive interventions that target beliefs and attitudes about sleep. So for instance, unrealistic sleep expectations, misconceptions about sleep, sleep anticipatory anxiety. So again, what is it going to be like tonight? What if I don't sleep? As well as poor cognitive coping skills. So how to manage difficulty with sleep during the daytime. And the last sort of target area is educational. So this involves sleep hygiene, and the treatment targets are inadequate sleep hygiene, which is just basically inadequate rules around your sleep functioning, the comfort of your sleep environment, and those types of things. So the last section that I want to focus on before I turn it over to Dr. House is, what can we do to get good sleep? So things that you should do are wake up and go to bed at approximately the same time every day. There's some degree of flexibility, but if we can sort of keep it pretty specific, then you can kind of entrain that circadian rhythm and make sure that your body is sort of in the right mindset or frame in order to be able to sleep and wake up when you'd like it to. Spend time outside in the light each day. I know that sometimes this is hard, especially when you happen to live where we do in Michigan, but trying to get outside, especially after your preferred wake time or early in the evening, in order to really give your body that stimulation and help it set its circadian rhythm. In the early evening, try to keep your lights relatively bright up until about 60 minutes before your desired bedtime. At that point, you can kind of begin to wind down and dim your lights. But if you keep the lights bright, you're much more likely to be able to keep awake until your desired bedtime. And then stay in dim light until your desired wake time. So if you happen to wake up too early, don't turn everything on right away. Instead, kind of maintain that dim light until it's the time you'd like to be awake. Do make sure that your bed is comfortable and that your bedroom is dark, cool, and quiet. Your body tends to sleep best in those kinds of circumstances. So, have some blackout curtains or hang a blanket over your window. Use white noise machines or earplugs in order to make sure that you're blocking out noises that might disrupt your sleep, and keep your bedroom as cool as possible. Eating regular meals is another way to keep your circadian rhythm in line. So eat your meals at regular times, again, after your preferred wake time, and not within 3 hours of your preferred bedtime. That will help avoid sort of disruption from digestion over the course of the night. Many people find that it's helpful to have a light snack in the hour or so before bedtime, some crackers or cereal or something like that, that's easy to digest so that hunger isn't something that's waking you up over the course of the night. And a few more do's. Make the last 30 to 45 minutes before bed a wind down time where you engage in quiet, relaxing activities that kind of prepare your body for relaxation and calm. And then dim the lights about 60 minutes before your desired bedtime. Avoid devices and technology during this time. And if you have to use it, keep it on the dimmest setting in order to avoid activating your circadian rhythm right before bed. Now, a few things that you should try to avoid or not do. Don't use the bed for wakeful activities like talking on the phone or doing your work, reading books. Instead, keep those activities to somewhere outside of the bed and use your bed only for sleep and sex. Don't lie in bed awake for long periods of time. If you're having trouble falling asleep or staying asleep over the course of the night, get out of bed and do something quiet and relaxing in dim light until you feel sleepy again and can return to bed. If you do wake up over the course of the night or too early in the morning, don't eat, work, exercise, or take a warm bath or shower if you're awake during that period of time, because that can activate your circadian rhythm and make it more likely that you wake up too early on subsequent days. Don't nap for longer than 45 minutes during the day. And if you do nap, try to keep it earlier in the day. So about 6 to 8 hours after your desired wake time, you should kind of cut off your naps. Be careful about using caffeinated products after lunch. They have a very long half-life and can hang out in your body for longer than you'd think, disrupting your overnight sleep and your ability to get restful sleep over the course of the night. Also, don't use alcohol to help you sleep. It tends to actually disrupt your sleep architecture as your body tries to digest it. And if you consume alcohol too close to bedtime, it can also lead to sleep disruptions, even if you initially feel a little sleepy. Don't exercise within 3 hours of bedtime. We really encourage you to stay active, especially if you're doing outdoor activities. But if you do it too close to bedtime, it can actually activate you and make you less likely to be able to fall asleep. And don't do anything that increases your body temperature about 90 minutes before going to bed, like a hot bath, a sauna, or a hot tub. These can actually make your body feel a little bit more activated and, again, make it more difficult for you to fall asleep. So that is the conclusion of my presentation, and I'm looking forward to your questions in a little bit, but for now I'm going to turn it over to Dr. House, and I will see you again soon.
Thank you, Greta, and I'm happy to be here with all of you. I will be sharing my screen. One moment, please. Okay. Well, I am very happy to be with all of you today, and I want to thank the organizers for the invitation to talk to you about the role of exercise in brain health. So just a few objectives to create a landscape for what we'll be talking about today. I'd like to identify an ailment called mild cognitive impairment and compare that against a more formal type of dementia or Alzheimer's disease. I definitely want to share with you about how exercise is medicine, especially for the brain. And I'll review some age-specific physical activity recommendations. And in highlighting exercise as medicine, I will be identifying some key literature that I think will be useful and accessible to all of you to help create the foundation of scientific knowledge for why exercise is so important for the brain and for cognitive health. So I thought we could start with a few brain facts. Fact number one, the human brain is only about 2% of our total body weight, but it occupies about 15% of total blood flow. And of that total blood flow, it accounts for about 20% of all the oxygen that we consume, and about 25% of all of our body's glucose utilization. So it's a very metabolically active tissue. Fact number two is that the brain is in a constant state of change. We are forming new neurons while others may die. And we're also making brain connections. And these brain connections can be considered like brain wiring. And these are influenced by things like physical activity, our cognitive activity, sleep, as we just heard very eloquently from Dr. Reglan, and nutrition as well. So I'd like to introduce you to a topic that some of you may be familiar with, and it's called mild cognitive impairment, or MCI, as I will be referring to it throughout the rest of the presentation. So many of us believe that MCI is an emerging pandemic. We would define it as a syndrome that is defined as cognitive decline greater than what is expected for an individual's age and education level, but that does not yet interfere with activities of daily life. And so an example of this would be, perhaps a normal aging related task would be you forget where your keys are, but you could retrace your steps and you could identify, okay, yeah, I put it on the couch where I normally put it on the table. But with MCI, these things are happening more often, and they're happening perhaps at a greater degree of intensity. So what we identified with mild cognitive impairment is a little bit greater than normal loss of brain volume. And so this image here, I have my cursor here to help identify the regions I want you to look at. If you see the blue highlighted areas surrounding this dark region in this brain image here, the blue images represent the loss of brain volume over a period of about 2 years. And so when we calculate the actual amount of brain tissue that was lost, this was about 2.5% per year. And so that's a bit more than what we would expect for the age-related or normal healthy aging, which is more of like 1 to 2% per year. So mild cognitive impairment can, from what we know right now, affects around 8 million older adults. We see that 8% of these MCI affected individuals are between ages 65 to 69, and up to 37% of those are 85 years and older. Unfortunately, though, MCI remains largely unknown to the vast majority of people. Around 82% of adults have little or no knowledge of it. And this was according to a very recent report that was published last month by the National Alzheimer's Association. So why do we get MCI? Well, many of us that study metabolism believe that MCI is linked to a dysfunctional brain metabolism that can be initiated by perhaps a genetic susceptibility. If there's a family history of dementia or Alzheimer's in your family, genetics certainly play a role. Environmental stresses are becoming more and more prevalent. Things like heavy metals and pollutants are definitely identified as potential causes for cognitive decline. We're also seeing that the antioxidant or the defense mechanisms of our tissues, especially in the brain, are probably being attenuated in some way. And we see this more consistently in individuals with Alzheimer's disease and with mild cognitive impairment. And then, of course, poor diet and lifestyle and a sedentary lifestyle will be more of the focus of what I will have to say today. But collectively, in this cluster of risk factors, you could see that how the metabolism may perhaps be perturbed by damaging of critical components within the cell, especially the mitochondria, which are used to generate our energy. And then that can lead to the formation and accumulation of amyloid plaques and tau plaques that then can actually reinforce the damage, leading to an uncontrolled cycle of exacerbation. And then ultimately, this would manifest in the symptoms of mild cognitive impairment. Now, cognitive impairment exists along a continuum. And so here we have normal age-related cognition. However, across the natural history of disease, we see that mild cognitive impairment would be the next step. This would be impairments in memory, thinking, or judgment. And then we would get into what we would call a mild dementia or mild Alzheimer's disease, where name recall becomes much more difficult. We misplace objects more often than not. Planning becomes very difficult. And then a moderate Alzheimer's disease, social withdrawal, sleep disturbances, personality changes start to be noticed by loved ones. And then, of course, then into the severe dementia or Alzheimer's disease, which is loss of awareness and surroundings, difficulty in eating and drinking, and then vulnerability to infections. And so this represents the continuum or the natural history of cognitive decline. And once an individual has mild cognitive impairment, they become at much greater risk for the development of dementia and full Alzheimer's disease. Well, the global population and the estimated costs of dementia are rising very rapidly. So what this graph depicts here is the number of individuals that had dementia in 2016. And here now we're approaching the year 2030. We expect that around 75 million individuals worldwide with an estimated cost of around $2 trillion. As we look towards 2050, we expect around 131 million adults worldwide, with 15 million of those in the United States to have dementia, which is estimated to be greater than $3 trillion in cost. But what if we could delay the onset of dementia only by 5 years? And so if we look at just the financial impact of delaying the onset of dementia by 5 years, we can see that in the short term, we don't really see much benefit. But as we project out to 2030 and 40 and beyond, you can see that the cost savings is going to be markedly exacerbated. And by 2050, we could save, billions and billions of dollars. Not only is there a huge financial incentive to treat dementia, but by prolonging the onset of dementia diagnosis by 5 years has an incredible improvement in quality of life and longevity for these individuals. Now, because of this urgent need to delay and treat cognitive impairment, there have been many attempts. Alzheimer's drug development is being done by all the major drug companies. But unfortunately, the vast majority of these compounds are failing. The brain is a very difficult organ to target without extreme side effects. And so in a period of time between 2002 to 2012, there were 413 compounds that were in the pipeline in the pharmaceutical industry, and 99.6% of them failed. However, in June of 21, the FDA granted the approval of the first drug in over 18 years for dementia, and that was called Aduhelm. However, this drug is not without controversy, and certainly, please consult your healthcare professionals, before thinking about any of these drugs. But it is, to date, very controversial in its actual function. So new drugs are extremely important, and the pipeline for these current drugs are ongoing, but their efficacy is unknown. My position, and it's probably no surprise from the title of my talk, is that I believe that exercise is medicine, and I believe exercise is probably one of the most powerful medicines that we can give to our bodies. And so I've created this little cartoon here for you to illustrate the therapeutic effects of exercise, and how, as we have a large aging population, and we have some of that aging population developing mild cognitive impairment, perhaps other dementias that may be related to things like Parkinson's disease or multiple sclerosis. And then, of course, we have the Alzheimer's disease, or full dementia, that will generate as a result of the natural history of mild cognitive impairment. But then if we look at this dash circle here, and we can see where the therapeutic effect of exercise can reach, it reaches almost all of the aging population. And my opinion is that it can reach the majority of the mild cognitive impairment. Many of the other dementias or cognitive declines that we see with Parkinson's disease and multiple sclerosis. And we're just now beginning to learn how exercise can affect the cognition within someone that actually has frank Alzheimer's disease. And so I'm going to be telling you a narrative about exercise and how it is medicine, especially related to brain mechanisms, and what those potential benefits of exercise are for your brain. So one of the most important things that exercise can do in terms of the brain is to increase blood flow to the brain, or this is called cerebral blood flow. It will be delivering oxygen, delivering nutrients, while taking away the waste products of our normal metabolism. We've come to recognize that exercise is very important for the growth of new nerve cells, or neurogenesis, and I'll be talking about that quite a bit today. We can also create new blood vessels. This is a process called angiogenesis. And as we create new blood vessels, then we're better able to deliver blood, deliver oxygen, deliver nutrients to those key areas of the brain that are important for memory and important for our cognition, our cognitive function. Exercise is also very important for creating new connections. Not only do we have neurons, but those neurons talk to one another. And so exercise has been shown to be very important for this term called neuroplasticity, the ability of nerves to talk to one another more effectively. We've seen neuroprotection. How is it that the cells of the brain, the neurons of the brain, can actually be resilient to insults such as oxidative stress or high-fat diet, or maybe a sedentary lifestyle? As we exercise more often, it seems as though our cells become more resilient to insults that would potentially damage those cells. And we think a lot of this neuroprotection, neuroplasticity, and neurogenesis is being mediated by healthy brain signals. And healthy brain signals are factors that circulate throughout the blood, reach the brain, and tell the brain to say, hey, let's turn on new nerve growth. Let's tell our brain and neurons to secrete more neurotransmitters that then lead to feelings of well-being or of good self-worth. And so collectively, if we look at all of these potential mechanisms, and then we extrapolate it out to the whole body, the benefits of exercise are to slow or reverse the shrinkage of key cognitive brain regions, such as the hippocampus, which is very important for the learning and memory and our cognitive abilities. We're also thinking that exercise is going to reduce the risk for neurodegenerative diseases such as dementia and Alzheimer's disease. And it helps our mood, anxiety, and depressions, and it makes us feel better. So as older adults, you're probably being encouraged to exercise by your healthcare professionals, perhaps by your family and your loved ones, or by your spouse. But there can often be confusion as to, what is the right amount of exercise, and how do I accomplish that? To be honest, I could give you a whole nother talk just on that topic, but I wanted to make sure that all of you had some inkling of what are the physical activity guidelines for older adults age 65 and older. And so to begin, older adults who participate in any amount of physical activity gain some health benefit. And that's not only on the physical side, but also on the cognitive function side. Some activity is good, but more activity is known to have greater benefit. And so what the recommendations are can be looked at twofold. If we accumulate greater than or equal to 150 minutes a week of moderate activity, that could be done perhaps in bouts. You could think of it as, let's do multiple bouts of greater than 10 minutes that then can equal the amount of activity that we need per day. Right, so if I did 3 10-minute bouts, then I would get 30 minutes per day. And if I did that 5 days a week, then I would meet the 150 minutes per week. So moderate activity would be, walking and perhaps some, vigorous or more vigorous housework, things of this nature. Now, we can also achieve our physical activity guidelines by saying if we met 75 minutes or greater of more vigorous activity. And this would be perhaps akin to something like stair climbing or joining an exercise class or walking at a brisk pace throughout one's neighborhood. And you can also meet the guidelines by, of course, having a combination of both moderate and vigorous activity. Other recommendations for older adults are to do exercises for muscle and bone strengthening at least 2 or more days a week. This would be using body weight type of exercises or resistance. You think of like the weights that you could use or resistance bands. We want to work the major muscle groups. And this could be things like weight training, carrying heavy groceries, maybe jumping in place or stepping up onto a box. All of these things are going to strengthen our muscles and bones. It's also recommended that you think about exercises that connect both the brain and the body. And these are exercises that help us with our balance and coordination. And examples of these would be yoga or Tai Chi, or perhaps balance challenges. And one example of this may be is that you're standing in place and you lift up one leg and you see how long you can hold that on each leg. Those would be great types of balance challenges that would then work both the brain and the body together. We definitely want to minimize the times that we spend in the sedentary position. This would be like prolonged sitting. So we've asked you to give us your attention for about an hour and a half this morning. My recommendation for you is that you stand up here periodically. And just by standing up, the literature has shown that we increase blood flow to our lower legs, and we actually increase the ability of our blood vessels to secrete important factors that are healthy for our cardiovascular system. So I invite you to stand now and then, maybe march in place for a moment or two and then sit back down and continue to listen. So collectively, the benefits are from these physical activity guidelines are we want to reduce our overall cardiovascular disease risk. We want to reduce our risk of falls. This then will improve our quality of life, our self-esteem, one's mood, and from the purposes of what I'll be talking about today are our cognitive abilities. But how do we know how much to do, and how do we know how strenuous we need to be exercising? So there is a general guideline that we give, which is called the talk test. This gauges the intensity based upon our ability to carry on a conversation. And so a moderate exercise intensity would be, as we're, say, walking with our spouse or with a group of friends, that we can carry on a steady conversation. But then when we go to vigorous activity, your talking may have to be interrupted by breaths. And so that would indicate that you're kind of right at that intensity that would be moderate to vigorous. We can also use things like heart rate monitoring devices. There are many, many apps. I mean, I have an Apple Watch here. It helps me to measure my heart rate. I use it very often. I use it for my own monitoring of my exercise intensity. These can be done using a chest strap that one may use. The watch, there's lots of of different tools. And so what we're looking for is to reach a target heart rate that would be somewhat between 60 to 75% of our age predicted heart rate max. So there's an equation that we can do is you take 220 and you subtract your age, and then you multiply that by the percentage of the heart rate you want to achieve. Moderate intensity would be somewhere around this range here, 60 or so percent. And then the vigorous intensity would be somewhere between 76 to more of the 95% or so target heart rate range. Then there's finally another method that you could use, and this is the rating of perceived exertion. So if you think of a scale 1 to 10, if we're at somewhere between 3 to 5, that's going to be a moderate amount of intensity. But then if we think about 6 to 9, that's going to be more vigorous work. And if we're out at 10, that's actually our max effort. We don't want to be at 10. We want to be somewhere between 6 to 9 for vigorous and 3 to 5 for moderate. So seniors who are more active, they actually have a lower risk of cognitive decline. And I'm going to share with you some very large studies that have been done over the past decade or two that highlight this fact. There was a study that came out of Honolulu and the Asian island nations. This followed 2,500 men, and they followed them from middle adulthood into later life for 3 decades. And they looked at their changes in physical activity and then whether or not they had an onset of dementia or not. And for those men who walked less than 1 mile per day, they were actually a double risk for developing dementia compared to men who walked more than 2 miles per day. So this is a very nice study. It was done longitudinally. This is a very robust type of experimental design because we can track that individual over time. Now, another example of that is that type of study was the Nurses' Health Study. This followed 20,000 women who were aged 70 to 81, and they followed them for 10 to 15 years. And what the research found was that women who walked 90 minutes per week had cognitive scores that were significantly higher than those that walked less than 40 minutes per week. There was another report that came out, which is called a meta-analysis. A meta-analysis is a conglomeration of many studies together. And what that the analysis does is it looks at the overall trends of many, many studies. And so this report identified 15 individual studies that had a total of 35,000 participants that were looked at from a 1 to 12-year period of time. And they found that those individuals that engaged in moderate levels of exercise were significantly protected against cognitive decline during the follow-up by around 35%. So collectively, these larger studies provide strong evidence that seniors who are more active have a lower risk of cognitive decline. Now, exercise is super important for our brain chemistry. The brain produces many neurotransmitters such as acetylcholine and dopamine. And when we look at things like dementia and Alzheimer's disease, there's actually a deficiency of the neurotransmitter acetylcholine. And then when we look at Parkinson's disease, there's actually a deficiency in the neurotransmitter dopamine. And so these neurotransmitters, they convey chemical messages between the neurons. And they're known to enhance brain activity, enhance cognition, mood, and sleep. And so again, many diseases are linked to their deficiencies. This slide was generously provided to me by Dr. Ava Feldman and the Neuro Network for Emerging Therapies. She gave me several slides, and her name will be highlighted down here when, when she's contributed in that way. So Exercise also boosts another type of brain chemical called serotonin. Serotonin is a neurotransmitter that is very important for our mood. We see serotonin levels actually decline with depression. And so if we look at this graph here, we see that individuals that don't exercise versus those that exercise at lower, moderate, or high intensity, as we increase our amount of activity that we do and the intensity of exercise that we do, younger adults with 24 years of age, they actually have an increase in their plasma serotonin. And then if we look at those beta endorphins are those chemicals that make us feel really awesome while we're exercising. If any of you recall, exercising at a very high intensity, you may feeling this like feelings of euphoria. Those are the beta endorphins. And so when we exercise more vigorously, we get spikes in beta endorphins. But if we don't exercise often, then we don't see those spikes. And so this then contributes to our overall feelings of well-being. Now, exercise is extremely important for our brain metabolism. And so just highlighting this cartoon here on this side, we can see that a healthy brain actually has very high amounts of glucose that's taken up into our brain and used for energy for the brain. However, as we move across the natural history of cognitive decline, we start to see that there's a decrease in the amount of glucose that's used for energy in the brain. And then here is a depiction of an Alzheimer's disease brain. And you can clearly see that there are regions that are shaded in green that indicate that the amount of glucose being used by the brain is much, much less in the disease condition. However, if we look at a study from 93 individuals that were at risk for the development of Alzheimer's disease, this is the mild cognitive impairment phenotype, is that if they exercise at low intensity, moderate intensity, or higher intensity, we can see that the amount of brain glucose uptake is much higher as we exercise from rarely, often to very often. Right? And so the take-home message here is that no matter whether we're doing low intensity, moderate intensity, or vigorous intensity exercise, the more often that we do it, the better our brain metabolism becomes. So again, highlighting that there is a natural decline in cognitive function with aging, the one that is age-related. And then we have a clinical cognitive decline that can be manifested with mild cognitive impairment or dementia. We see that the slopes of these trajectories are much different. And so what is it then that distinguishes those older individuals that have a gradual worsening or age-related normal decline in cognition versus those that experience more rapid declines in their overall cognitive abilities? Well, from what we've learned in the exercise literature is that there are a group of compounds or factors that we call the good stuff induced by exercise. These bioactive compounds released in the circulation in response to the physiological demand of exercise. We collectively call these exerkines. And so we believe that they mediate the benefits of exercise. And so here in this cartoon, we have a individual cycling on a bicycle. And you can see that through many of our tissues, the adipose tissue, the skeletal muscle, and the liver, that there are factors that are secreted from these tissues that collectively accumulate within the blood, and then they reach the brain. And then at the level of the brain, they provide signals to create new neurons, to enhance cognition, to enhance our mood, and to create new brain connections. So what does the literature say in this regard? Well, we know that exercise increases the birth of stem cells. Again, neurogenesis. So how do we create a new neuron? So we have actually cells that are embedded within all of our tissues that are what are called stem cells. And if the right signal talks to those cells, then those cells can then start to grow into the tissue in which they're embedded. In this case, if we have a neural stem cell or a neural progenitor cell, and the right signal comes along, perhaps an exercise-mediated signal, then these resident stem cells will then start to change into a functional and mature neuron. And so we have seen this in animal models. There are plenty of studies in rats and mice where we can harvest the brains of these rodents, and we can see that the brain is actually generating new neurons. But of course, we can't do that in humans. So what can we do in humans to help identify whether or not exercise can create new neurons in the brain? Well, we can do a bunch of imaging techniques through MRI and through other scanning-based types of approaches. Now, the issue here is that the brain hippocampal volume, the region of the brain that's important for learning and memory, it's depicted here. It's kind of like a bean type of shaped structure within the brain. There are two sides of it, both a left and a right hippocampus. What we see is that brain hippocampal volume can shrink around 1% to 2% annually in healthy older adults. But as we develop cognitive impairment or mild cognitive impairment, we start to see more like 2.5%, 3% loss per year. And so that would be greater than what's expected. And so the literature would indicate that our overall aerobic fitness, our overall fitness level, is associated with healthier brain volume in older adults. And so these data are shown here. In this schematic, I have hippocampal volume that is plotted against our overall cardiorespiratory fitness. And so you can see that there is a very strong relationship between the higher amounts of fitness one has, the higher amounts of hippocampal volume we have. And so just for some calibration in terms of our overall fitness levels, for older adults age 65 years and older, an excellent level of fitness would be considered for both men and women on the lower side, men on the higher side, around 32 to 37 milliliters per kilogram body weight per minute. This is the amount of oxygen uptaken per minute per kilogram body mass. And so you can see those individuals in the excellent range are, kind of in this upper quadrant of our graph here. And then if we have more average fitness, that's between 22 and 28, lower for women, higher for men. And so that is kind of in this range here. Now, clearly in this graph, we have some folks that have poor fitness, and we have some individuals that would be very, very high fitness levels for this age group. But again, we see this continuum of how fitness is related to brain volume. Now, what some really nice studies did in 120 adults, they showed that aerobic exercise training, that 150 minutes per week type of approach that I mentioned to you earlier, is that if you were engaged in that type of activity, then it was effective at reversing hippocampal volume loss and actually improving memory function. And this was in 120 adults. And here you can see some of the data here. Here we have the baseline look at the hippocampus, the volume of the hippocampus before the study began. At 6 months into the intervention, we see that those individuals that went into the exercise program, they start to see increases in their hippocampal volume. Whereas those that went into the control group actually experienced that normal decline in the hippocampal volume that we see with aging. As we continue to exercise into 1 year and beyond, we see that hippocampal volume increase even further. But in the control group that had no exercise at all, they declined even further. And so when we plot all of the individuals in terms of how much they changed in their hippocampal volume versus how much they changed in their overall cardiorespiratory fitness, we see this relationship here. So clearly we have a group of individuals that did not respond well. that actually experienced a shrinkage in their brain volume because they did not improve their cardiorespiratory fitness. But for the vast majority of individuals, they did improve their cardiorespiratory fitness and they did improve their overall hippocampal volume. Now, what about exercise intensity? How do we know how much to really exercise at? How intense should we really be exercising? Well, again, exercise intensity refers to how hard your body is working during that physical activity. And so that percentage of our maximal heart rate, that 220 minus our age, that's our intensity value. And so low intensity, again, somewhere between 40 to 60, moderate between 60 and 75, and then high between 76 and 96%. And so what we have identified in the literature is that vigorous or higher intensity aerobic exercise results in greater improvements in our overall cardiorespiratory fitness. And it has large reductions in overall heart disease and premature death, the development of diabetes, the risk of cancer. And now I'm going to show you that it improves our overall risk of, or reduces our overall risk of developing cognitive decline. What we see is that the higher amounts of exercise intensity we give, the actual greater amounts of these exerkines, or that good stuff during exercise, we see more of that appear into the blood. So what these data show here is that a factor called brain-derived neurotropic factor, one of those signals that help initiate new neurogenesis, is that if we exercise at either moderate or higher intensities, we see increases in BDNF, but there is a greater increase in BDNF in those that exercise at higher intensity for longer periods of time. There are also factors that are known to be secreted from the skeletal muscle that improve our overall metabolism. And so, as I mentioned before, as we exercise more vigorously, we see more glucose metabolism in the brain. And this may be related to some of these factors that are secreted from the skeletal muscle. And so we look at either low, moderate, or high intensity exercise. The greatest amount of change in this factor, IL-6, occurred when we had the highest intensity exercise. There's also factors that are secreted from the fat that also help to regulate our overall appetite and our overall metabolism. And these factors are known to initiate changes within the brain as well. This particular one is called adiponectin. And we again see that with higher intensity exercise, we see the greatest amount of change in that particular factor. Now, I have just a couple more slides before I wrap things up here. As I mentioned to you earlier, cognitive impairments also occur with other types of cognitive diseases, such as Parkinson's disease. So those individuals with Parkinson's disease, they may demonstrate memory difficulties, slowed thinking, maybe some confusion, and they may actually also progress into dementia. And so what in Parkinson's disease clinical care and in research, we use a score which is called the Universal Parkinson's Disease Rating Score. And so what this means is that the higher amount of score that you have on this rating, the worse you are off in your overall disease progression with Parkinson's disease. But what we found is that when you exercise at higher intensities versus moderate, or having just your overall usual care, that the higher intensity exercise group actually experienced the least amount of degradation in their Parkinson's disease symptoms over a period of 6 months. And so these data that I show here have led us now to a large multi-center phase 3 clinical trial in which the University of Michigan, School of Kinesiology is a participating site, and I am the PI or the principal investigator for that study here at the University of Michigan. And so what we're doing is we're randomizing early stage Parkinson's disease individuals into either a moderate exercise group or a high intensity exercise group. And we're seeing how much that attenuates the overall progression of their Parkinson's disease symptoms over a period of 2 years. That study is ongoing right now. You can reach it through this website here, and we're currently enrolling new subjects. So before I wrap things up here, I want to highlight that a healthy brain requires a healthy body. As we become sedentary and we gain in adiposity, we start to see things that are bad for our body: poor metabolism, higher blood pressure, increases in risk in our overall cardiovascular disease and obesity, and our muscle function starts to decline. But as we exercise more, we become more physically active, we see improvements in every one of these factors. And so collectively, the brain and the body are connected. And if we have a healthy body, we will have a healthy brain as well. The three most important points that I want to leave you with today is that we need to have early intervention. Let's identify mild cognitive impairment early, and let's exercise so that we can prevent its conversion into more serious forms of cognitive decline, including dementia and Alzheimer's disease. The evidence around lifestyle change is robust. So it's science-based. And it is definitely shown that lifestyle intervention, especially exercise, can improve cognition, improve our brain function, and hopefully then prevent our progression into more serious forms of dementia. With the aging population, with the number of individuals that are projected to have dementia over the next 20 to 30 years, there's an enormous opportunity, and there's a huge unmet need for this growing population. I'd like to leave you with these resources. I want to highlight the mHealthy group here at the University of Michigan that provides resources and opportunities for you to engage in healthy lifestyles. The Michigan Alzheimer's Disease Center is a wonderful resource and an option for people that either have a loved one with dementia or may be suffering from dementia or mild cognitive impairment right now. The Neuro Network for Emerging Therapies, that's part of the neurological department here at University of Michigan. And I'd like to especially thank Dr. Eva Feldman and Shoshana Frishoff for their help in some of the slides that they provided for me today. My own lab, the Human Bioenergetics Lab, you have a full listing there of all the studies that we have going on. The Parkinson's disease study is listed there, as well as some studies we have with diabetes and exercise, as well as studies that we have ongoing or will soon to be ongoing and related to mild cognitive impairment and exercise. So stay tuned for those. They'll be posted here within the next several months. We'll be looking to enroll participants into an exercise study similar to the ones that I highlighted to you today. Please visit us at the School of Kinesiology, see the fun things that we have going on. And of course, the Alzheimer's Disease Association is a wonderful resource for all of the dementia-related needs that you may have. And so I am going to leave you there, and I'm very happy to answer your questions along with Dr. Regolin.
Thank you, Dr. House. Thank you, Dr. Reglin. We have lots of questions for you, so I'm going to go back and forth between you with the different questions. We'll start with Dr. Reglin. So what do you think of the Inspire product for sleep apnea?
So the Inspire product is an implantable device that helps to monitor and regulate sleep and airway functioning. It is implanted via kind of an outpatient medical procedure, surgical procedure. The Inspire device is very helpful for people who have kind of intractable sleep apnea. So for instance, they've used CPAP, they've used an oral appliance, and they just don't seem to be effective in treating their particular presentation of sleep apnea. We don't typically recommend it unless the sleep apnea is very severe. And again, unless they've kind of gone through multiple other treatment options, just because it does involve a surgical implantation. And it's very difficult to remove the device once it's implanted. So if it's not effective, you're kind of stuck with this implanted device in your body. So certainly for folks who have tried and failed with CPAP, it's a treatment option, but one that we don't consider kind of a first line treatment.
Thank you. Someone else asks about yoga, and is yoga helpful for those that have sleep issues? And then also alternatively, Dr. House, is yoga also a helpful form of exercise to combat dementia?
Go ahead.
Dr. House, do you want to take that first?
Sure. So there's not a lot of research in that area, but certainly yoga has a mind-body connection. And if we can calm our minds and we can become mindful of our body movements, then it's anticipated that there are benefits to cognitive function as well. However, there's not very many good studies yet in that area.
And there have been some studies showing that yoga is a helpful strategy in terms of, again, like Dr. House said, kind of calming your mind, your body prior to or in anticipation of sleep. It can also be a gentle form of exercise that can help to sort of prime the body for sleep later in the day. Many people find that gentle stretching, whether it's in the kind of domain of yoga or in other areas of focus, can be very helpful, again, in priming them for sleep. There's not, for folks who have like an insomnia disorder or sleep apnea, there's not necessarily evidence that it's going to cure those conditions, but can certainly be like a helpful piece of a routine to incorporate.
Thank you both. Dr. Ragland, this is for you. We have several questions actually asking about the low light in Michigan, especially during the winter time. So people are asking if things like a bright light therapy or melatonin supplements, what is your opinion on dealing with that low light situation we have for 6 months out of the year here?
Absolutely. I mean, great questions. So yes, there are environmental factors in Michigan and in many other parts of the world that make it difficult to get adequate bright light. So the first thing that I would recommend is on the days when the sun is shining, even if it's cold outside, get outside as much as possible to get that natural bright light. That really is our best source of light. That being said, bright light treatment modalities like a bright light therapy lamp are very, very helpful in supplementing our light exposure, particularly during the dark times of the year. If you are using a bright therapy lamp, we tend to recommend going for a 10,000 lux light. And I'm going to say that again, it's 10,000 lux light, and that is sort of the brightness at which you're sort of best able to absorb it, and it's going to most impact your circadian rhythm. If you use it first thing in the morning around the time that you are intending to wake up, that's going to kind of help to entrain your circadian rhythm. And if you're having difficulty falling asleep too early in the day, you can use that bright light therapy early in the evening in order to sort of push your bedtime back a little bit. You also asked about melatonin use. So melatonin has a lot of usefulness if you are having sort of a misalignment in your sleep scheduling. So if you're going to sleep too early or too late, but as a sleep aid, it's generally not that helpful. It doesn't tend to be terribly sedating for most people. And it has some impacts on kind of your natural melatonin secretion that can make it have some long-term implications that aren't as desirable. One thing to keep in mind is if you are using melatonin to sort of shift your sleep time either earlier or later, you really only need a little bit. So many times melatonin is sold in 5 to 10 milligram capsules or even higher than that. And we really find that there's a plateauing effect after about 2 milligrams. So if you're taking 2 milligrams or more, you're not really getting any more effect than you would at even 0.5 milligrams.
And we had a couple questions that kind of go along with that same topic. A couple of viewers are asking about cannabis or about CBD in order to help with sleep.
Yeah, another great question. So now with many of the restrictions on cannabis products being lifted in a lot of jurisdictions, there's a lot more use of cannabis products around sleep. There's still not a whole lot of research evidence to support the use of cannabis in sleep, but many people kind of anecdotally do find it helpful. I would caution folks that we have very little understanding of kind of the specific strains and dosing, especially because there's very little regulation around strains and dosing. So some people may find that cannabis products are helpful, but then may use a different product that is not as helpful. And the same goes for individual differences. So some people may find cannabis very sedating and might find it helpful for sleep, but other people might find it very activating or even anxiety producing and might make sleep more difficult. Along those same lines, we do find that with most substances, cannabis included, even though it may help people fall asleep, it can negatively impact sleep architecture so that people aren't getting as good quality of sleep over the course of the night or don't feel as rested when they wake up in the morning.
Great, thank you. Dr. House, we have some questions on exercise. One viewer would like to know how much time per week on weightlifting would be effective?
Yeah, the recommended guidelines are 2 or more days a week, but certainly some of this can be individual. If you prefer weightlifting as your overall mode of exercise, then engage in that. There's very little evidence in terms of resistance training and cognition, but that data is emerging and it should be out hopefully within the next several years. But at a minimum, I would say 2 or more days a week.
Thanks. And we have a few questions. I'll kind of tie these in together on people with mobility issues and exercise. So severe back issues, heart failure, asthma. How effective, how can people with mobility issues be able to exercise enough to where it would be effective?
Yeah, so we haven't yet established what the dose response is in terms of how little bit of exercise benefits cognitive function. And so my recommendation is that do whatever you can, do as much as you can. For those that have mobility issues, wheelchair bound or knee problems, as I looked through some of the comments in the Q&A, there are many upper body types of approaches that can be used. There are things called an arm ergometer that may be in your gym, where you grab a hold of these wheels and you use the resistance in this way. And so those are very effective at increasing heart rate and increasing blood flow. There's also resistance bands. There are things that can be done just by sitting in the chair, and those can be directed through, say, a physical therapist. For those that have other comorbidities where exercise intensity may be contraindicated, like heart failure and asthma, there are benefits from lower intensity exercise, but all of these things need to be discussed with your healthcare providers, and hopefully then work with maybe a physical therapist or some type of exercise professional.
Great, thank you. And this question was directed toward Dr. Ragland, but certainly Dr. House, if you can chime in as well. I'll ask Dr. Ragland first. Can chronic insomnia increase possibilities of dementia? So this viewer says, the brain repairs do not occur when sleep is disrupted constantly. Is that something that you should worry about?
Well, so again, a great question. So there's sort of a fine line between worrying about it and being aware of it. So yes, we know that chronic sleep deprivation can be both a contributor to cognitive deficits and also an indicator of cognitive decline. So individuals who have mild cognitive impairment, as well as other dementias, can begin to exhibit sleep disruptions as kind of one of the symptoms of those disorders. So yes, it's best to not have chronic sleep deprivation resulting either from insomnia or other sleep disorders. That being said, it's sometimes people can worry a little bit too much about the impact of their insomnia on their cognitive well-being, and that can increase sort of that cognitive arousal that comes with bedtime, the fears around being unable to sleep, which can in turn worsen insomnia. So I kind of want to walk a fine line there. I don't want to terrify you, but yes, it's not great to have loss of sleep. On the other hand, don't worry about it too much. Try to sort of understand that as much sleep as you can get is going to be a positive. But I'm sure Dr. House has additional information on the impact with.
Not more than you've added, but I will say that normal physical activity patterns, as you indicated, are going to help promote better sleep architecture, as long as it's not done within 3 hours of sleep time.
Absolutely.
Thank you. Wonderful answers. So if Dr. House, a viewer would like to know, how do intellectual exercise and physical exercise compare when combating dementia?
Yeah, things like crossword puzzles, Sudoku, mental games and so on. They are extremely important, and they shouldn't be however, I don't believe they should be a substitute for exercise. Do them in combination. Definitely leading a life that is engaging with other individuals, having social support, engaging in complex mental tasks, all of that is going to help create those neural connections that we had discussed and maintain them over time. And so continue to do those. And then if you have the opportunity, add the exercise in. And my bias would be that you have a synergistic benefit or an additive benefit by adding one on top of the other.
Great, thank you. Dr. Ragland, is amyloid plaque a symptom or a cause?
I think this one might be for Dr. House.
Oh, I'm sorry. They didn't specify. Sorry about that. Dr. House, let's go to you.
We don't know. It's hard to say. We can't really get at human brains until one has passed away, and they've given us access to their brain to view these things. The literature would suggest both, and there's been a great deal of controversy in this area. The drug that I had mentioned, the new one that was approved in 21, that does target amyloid plaques, but that's why it's controversial in its nature, because we don't know if it's a symptom or a cause. And so the research is still ongoing in that area, unfortunately.
Thank you. Dr. Ragland, this one is for you. So someone would like to know about their sleep pattern and how it's changed over the years, getting up and walking around a few times when they do wake up and they're able to go back to sleep. And that is happening more frequently as they age. Should they be concerned about their changing sleep pattern? And if so, they're sleeping less than 2 hours during each period. Is that something to be concerned about?
Great thoughts. So as I mentioned, as we age, we tend to have more periods of wakefulness over the course of the night. Sometimes people find that during that period of wakefulness, if they get up and kind of move around, use the restroom, they're able to return to sleep relatively quickly. The times when we think that the overnight wakefulness will become problematic is if it's for very extended periods of time or people are unable to fall back to sleep. And so that's what we would consider kind of middle insomnia, where you're kind of waking overnight and having difficulty falling back to sleep. So if you're able to return to sleep, but you're noticing an increase in overnight wakefulness, that's pretty normal and not problematic unless it's really distressing or causing you daytime dysfunction. In terms of sort of the period between wakefulness, there's no sort of specific amount of time that you have to be getting between each wakeful period, but 2 hours would certainly be enough to kind of get you through at least one cycle of sleep where you're kind of going through all of the different phases of sleep. So that should be adequate. Again, as long as you are feeling rested during the day, there's no problem with that particular sleep pattern.
Thank you. Dr. House, these questions kind of go together. A viewer would like to know, what do you find to be the most effective heart rate monitors available commercially, including a Fitbit? And do you recommend a wrist versus a chest band? What are the best ones?
Yeah, unfortunately, I don't have a stock in either of those companies, but the wrist-based ones, especially like the Apple Watch, the Garmin's, those are just very, very convenient. And people tend to adhere to using those more often rather than using the chest-based one. Now, the chest-based one is in direct contact with the skin and tissues that are above the heart. And so they're thought to be more accurate. However, both the skin, both of the chest-based and the wrist-based use what's called galvanized skin sensors, which means that they're only detecting the activity through the skin. And so I think it just determines, or it really just comes down to what your preference is. What are you willing to use on a daily basis in order to track your own personal health in the way that suits you best?
Thank you. And Dr. Ragland, what are some sources of cognitive behavioral therapy for insomnia?
Great question. And I was admiring Dr. House's references page at the end. So if you have any questions about your sleep, you can contact us in the Behavioral Sleep Medicine Clinic here at the University of Michigan. We're housed in the Outpatient Department of Psychiatry. We also have a very good sleep center here at the University of Michigan that you can refer to if you have questions about your sleep. If you're looking for a source of cognitive behavioral therapy that doesn't involve speaking directly with a provider, there is an app called Sleepio, Sleepio, and they offer sort of semi-individualized advice for your sleep, but it is a paid app. So, there is some kind of fee as you download it or as you engage with it. The VA also offers, the Veterans Administration also offers a lot of really great information related to cognitive behavioral therapy, and they have an app themselves called CBTI Coach, and that's got some tools in it for helping you to change your sleep, including a sleep diary function where you can track your sleep, but their website on sleep is very good.
Great, thank you. Dr. House, if you normally exercise 60 minutes a day, 7 days a week, moderate exercise, but you still get diagnosed with MCI, what is your best option for exercise? Should you increase that amount? What are some options for somebody in that situation?
Yeah. Unfortunately, there are so many causes of MCI, and in this particular circumstance, it may be genetic predisposition, or it may be perhaps other underlying factors. And so it sounds to me as though you're doing everything that you need to do. And I would say continue along that path. If it's safe and recommended by your healthcare team to increase exercise intensity, then at least from the data that I've presented today, that would be of potential additional benefit.
Thank you. Dr. Ragland, I'm going to put a couple of questions together. One viewer would like to know, can indoor light exposure through the window be as effective as being outdoors?
Usually slightly less effective just because of the filters in the glass. However, if that's what you've got, get it. You walk up to the window, look out the window, and try to get it sort of as directly into your eyes as possible.
Great, thank you. And then also reading and bright lights before sleeping at night and during wakefulness. How does that affect your sleep specifically? They're asking.
Bright light as you're trying to fall asleep or over the course of the night can disrupt your circadian rhythm and sort of make your body feel like that's a time when you're supposed to be awake, whereas you might actually want to be asleep. So we discourage bright light at any time during kind of your intended sleep period. Reading is a great option for something to do in kind of your wind down time prior to bed, or if you're unable to sleep over the course of the night and need to kind of get out of bed and do something relaxing but enjoyable. I would just say, don't start a mystery that you can't put down right in the middle of the night, because it might be hard to return to sleep when you want to. So sometimes reading something that maybe you've read before, or reading something that's interesting but not quite so engaging, can be helpful in the middle of the night.
Thank you. And Dr. House, this is an interesting question. In the first half of the 20th century, kids had much more exposure to lead than kids today, due to industrial pollution, lead toys, lead paint. Do researchers think that this heavy metal exposure may be a factor in cognitive impairment in older adults today?
I can't speak to the evidence directly, but I had mentioned these environmental exposures, and definitely heavy metals, lead, industrialized areas seem to have higher rates of neurodegenerative diseases. And one hypothesis that is because of these industrial pollutants and heavy metals. These studies are difficult to do in humans. It's not ethical to expose people to see whether they, of course, develop the disease, and so then we have to focus on animal models and things like treating cells in a dish, which of course lack the translation and lack the whole system. And so it's a difficult question to answer, but at least that's my knowledge of the evidence.
Thank you. Dr. Ragland, we have a couple of questions about light, using different colored lights, red light in your bedroom in the hour before you go to sleep, or using blue light blocking glasses to read before bed. Would either of those have any kind of effect?
Absolutely. So we find that red light is less activating for your circadian system. So for some people, putting a red light bulb in a lamp in their room or wherever they're spending time prior to bedtime or in the middle of the night is helpful. We recommend this, for instance, for new parents when they're changing diapers in the middle of the night or feeding their babies, just so that they don't activate their circadian rhythm when they're up. And blue light restricting glasses can be very helpful, as well as sort of setting your device onto the blue light shift mode, where it goes from emitting primarily blue light to more of kind of the red yellow type of light can be helpful. The biggest thing though is really keeping those lights dim, whether it's from a device or a lamp. So if you can switch to like a 40-watt bulb instead of a 100-watt bulb, that's going to be helpful in terms of reducing the circadian activation.
Great, thank you. And Dr. House, this viewer would just like to confirm that they said they're surprised to hear how strongly vigorous exercise is more helpful than moderate exercise, and just wanted to confirm that.
Yeah, well, I read that comment, and you also had mentioned use it or lose it, right? And so,
yes.
Again, I had said that any exercise is beneficial. And the more often that we exercise, the more benefits that we're going to achieve. What it does appear is that the intensity of the exercise is also really important. But our knowledge of that up until now has been primarily focused on cardiometabolic disease, like heart attacks and strokes and diabetes risk. And so the evidence there is pretty clear that higher intensity is more beneficial. When it comes to cognition, it seems as though we are seeing more benefits on these neurotransmitters and potentially in, say, the Parkinson's disease space. I wouldn't say that there's been a really large randomized controlled trial on moderate versus high intensity for dementia or cognitive outcomes as of yet. But those data are coming out, and we'll have to see. But I would just continue to do whatever you can as much as you can, and I'm sure that your body and your brain will benefit from that.
Thank you. Dr. Ragland, any tips for dealing with jet lag in terms of sleeping and insomnia?
Sure. Yeah. So jet lag or time change, which may be a thing of the past. Let's keep our fingers crossed on that. So basically, your body can adjust to about 30 minutes of change per 24-hour period pretty easily without having much of a problem. So what I typically suggest for people when they're traveling is to try to begin to adjust to the new time zone prior to departure. So for instance, if you're flying somewhere that has a 3-hour time difference, it might take you up to 6 days to really get into that time zone fully. So if you can begin a couple of days prior, like 3 days before you travel, to shift your clock about 30 minutes each day, by the time you get there, you're halfway there. If you're going for a period of 3 to 4 days, maybe even 5 days, it might not be worth shifting your time zone because you might not really fully shift by the time you have to return home. If you're going for any period longer than that, a week to 2 weeks, then yes, begin to shift prior to your departure, and then again before your return home, so that you can kind of at least cut the difference before you leave.
Thank you.
Yeah.
And Dr. House, how do you determine if you have a good heart rate when exercising, if you're taking blood pressure meds?
Yeah, that's a great question. There is a class of blood pressure medications called beta blockers, and the beta blockers actually inhibit your heart rate response during exercise. And so if you're on a medication like that, you're not going to be able to do that 220 minus your age equation. And I would recommend that you speak with your physician or cardiologist in terms of what the best exercise prescription is for you, because there's likely a reason that you're taking the beta blocker, and exercise may not be the right thing to do without guidance from your physician.
Thank you. And we just have a couple of more questions. Dr. Ragland, do you have any tips for people who fall asleep during lectures, concerts, plays, etc.?
I certainly hope it wasn't ours. But yeah, so sometimes, as Dr. House mentioned, it is very helpful to stand if possible. So if you have periods of sleepiness during the day where you feel the urge to take a nap or something like that, sometimes kind of going with the inverse behavior can be really helpful. And this is typically the time that I recommend people engage in kind of their moderate level activity, take a walk around the block, or if you're listening to a lecture, stand in the back of the room or stand up while you're engaged in the Zoom call. If this is something that's happening really constantly for you, or you're experiencing sleepiness in other areas of your life, for instance, while driving, it is worth touching base with your doctor about whether a sleep study could be indicated, because it could be a sign of another sleep disorder like sleep apnea, if you are having that intense daytime sleepiness that's hard to fight.
Thank you. And one last question, do over-the-counter PM pills, for example, Advil PM, does that help or hinder your sleep quality?
So a lot of people are taking these over-the-counter sleep medications, and you can buy like massive jugs of them at Costco. And most of them rely on an antihistamine similar to Benadryl to help make you a little bit sleepier. There's no problem necessarily with taking them once in a while, especially if you're anticipating a night where you might get less sleep, or you're having sort of a short-term concern with your sleep. The problem is that over time, people tend to really quickly develop tolerance to these kinds of antihistamines, so they become less effective over time, and they can also, require more medication in order to get the same effects. Long-term use of antihistamines, especially on a regular basis, has been linked to cognitive decline, however, so it is not something that I recommend for chronic insomnia or just for regular use to aid with sleep.
Great, thank you. And that wraps up our list of questions. So as our viewers know, this recording will be available on YouTube in the next week or so. And they were wondering, I did have a question about would the resources be available? So if we could get a copy, maybe Dr. House and Dr. Ragland, of the resources that you used in your lectures, if we could attach that with the email. We have some folks who would really like to take advantage of those. So if that's possible, thank you. A big thank you to Dr. Ragland and to Dr. House for today's program. Thank you to our audience for joining us today. We'll send out all of the necessary components to this program as soon as they're all set and edited and available. You're also expected to see the recording of this live session in the YouTube playlist in about a week. There are recordings of our previous presentations available for you to see on YouTube. There's a playlist that you can bookmark. And that being said, we hope to see you in the future. Thank you again to our presenters, our speakers today, and enjoy this beautiful day, sort of. It's rainy, but we're kind of in the middle, so enjoy.